Welcome to Senadipan Education Foundation once again. Education isn't something you can finish. Actually, we started this educational programs way back in 2007 by releasing a brochure of our education program by Antonio Longo, the founder of Stapler Hemorrhoidectomy. Then we started this Senadipan Education Foundation program in 2012 by releasing a set of educational DVDs, and it was released by Professor Seon Han Kim from Korea. We used to have free fellowship programs in 6 months and 1 year fellowship, and in basic and advanced laparoscopy courses. We used to have contact classes. We used to give hands-on training. With the advent of COVID, we transformed this education programs to online. And the logo was inaugurated by Dr. C. Palanivelu last year in July. And then we started live surgeries in online platform. We did the first live procedure in Facebook Live in April. That was a laparoscopic anterior session. Then we did a live YouTube program, Laparoscopic Pupils, in August 2020. The link was shared to members of Senadipan Education Foundation. And then we started having live lectures with the world leaders. Actually, we have an appearance in social media. We have almost 15 WhatsApp groups, and we have a Facebook group as well. In the season 1, we had 28 webinars with world leaders. And then we had the appearance of almost globally. One of the webinars, we can see that 1,303 participants were there from 56 countries, making this one of the largest virtual platforms in the world. And we have a Senadipan Education Foundation YouTube channel, which is all the webinar videos are available free in the YouTube channel of Senadipan Education Foundation. Today, we have two eminent people in the endoscopy field, and the topic is endoscopic management of surgical indications. We have Dr. RAJESH and Dr. LAKHTAKIA. Dr. LAKHTAKIA is the Director of Endoscopy and US Asian Institute of Gastroenterology, Hyderabad, India. He took his graduation MBBS from Maulana Azad Medical College, then PG from PJ Chandigarh, and DM from SGPJ, all well-recognized institutions in India. He is the immediate past secretary of Society of Gastrointestinal Endoscopy of India. Presently, he is vice chairman of International Committee of the American Society of GI Endoscopy. He has got more than 140 publications in index journals, and he is a peer reviewer in many of the international journals. Also, he is a visiting professor in University of Medicine, Myanmar. He is a technical committee member for EUS in many of the international EUS organizations. And Dr. RAJESH PURI is Senior Director, Medanta Institute of Digestive and Hepatopancreatic Sciences. He graduated from SNM College, Jodhpur, took his MD from there only. And he was the gold medalist in DNV gastroenterology. He got the medal from the President of India. Personally, he is the Secretary of Society of Gastrointestinal Endoscopy India, and also the Governing Council of member of ISG. He has got 20 years of experience in the field of interventional endoscopy. His keen interest is in teaching techniques of interventional endoscopy, and he has got various social and charity activities, involved in many of the charity activities in India. We are really honored to have both the prominent figures in the endoscopy from India, Dr. RAJESH PURI and Dr. LAKHTAKIA. Before giving the mic to the moderator, let me ask the participants to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene. Everybody will be given permission to unmute their mic if they want to speak something. If you are in a portable device, please mute your audio and hide your video. The next webinar is going to happen next Sunday, same time on chronic calcium pancreatitis. The speaker will be Dr.RAJESH from Kochi, India. And it will be moderated by Dr. Pradeep Rabela, who is surgical gastroenterologist, Asian Institute of Gastroenterology, Hyderabad, India. You can write to me at senadipan@gmail.com for any doubts or any details regarding the webinars. Thank you. I am stopping sharing this video. I hand over the mic to Dr. Sundeep LAKHTAKIA for the proceedings.
Thank you, Dr. Baju. Good evening, everybody. As Dr. Baju very kindly introduced myself and Dr. Rajesh, I think without wasting any time, we will move forward on a very broad topic. As you must have seen the flyer, endoscopic management of surgical indications. It's almost like a textbook where endoscopy and surgery meet together. They'll have several indications how to do differently endoscopically. I am told that most of the audience today is belong to the surgical specialty with some presence also of the endoscopist. So we discussed earlier, and we have Dr. Rajesh has tailored his talk in such a way to cover some of the endoscopic standard indications, and there'll be several things which may have got missed out based on the broad nature of the talk, which I'm sure if you can address in the chat box, we can discuss it in the end of the talk. May I now introduce my very close friend, Dr. Rajesh Puri, the Secretary of Society of GI Endoscopy of India, to take over from now on. Keep posting your questions and comments in the chat box so that we can adjust and refer you by your name as well.
Thank you, Dr. Sundeep. Is my slides are visible?
Yes, they are. Please go ahead.
Thank you, Dr. Sundeep, and thank you, Dr. Baizu, for giving the kind introduction. And as Dr. Sundeep, my colleague, has told that this is a very broad and the wide topic, endoscopic management of surgical indication. It is difficult to cover, I think, in hours time. So what I have decided is to talk about the two important topics, that is pancreatic necrosectomy and POEM procedure in detail, and rest of the remaining, I'm going to show the videos and many more topics which will be going to left, which we can discuss during the chat box. So you are free to ask any question. And I always feel, this is my feeling, we grab the procedure from surgeons, and surgeons always has a helping hand for us. Whenever we are in difficult situation, the surgical colleagues help us and we eat their business. They don't jump on our, at least in my career I have seen. So logically, we always consider to be a two parallel running field. The borders are blurred between the two specialties with the passage of time. We are overpowering each other field, lot of crossover between the cases now. But I always feel this is not the competition. This is always be a complementary to alternative to each other. So if you look at the endoscopic management of surgical indication, this is a huge list. And beside that, there are also many procedures which earlier the surgical colleague was doing, like esophageal stenting, gastric outlet, colonic stenting, where the surgical colleague has to go for the colostomy, or they do the gastrojejunostomy. But with an advancement of endoscopic procedure, it is taken over by the gastroenterologist because they are less invasive, less time consuming, cheaper, and give the better quality of life to the patient. And that's why, because in the era 2021, if you look at the surgery started with the open surgery to laparoscopic surgery to minimal port surgery. And now the era is of endoscopic surgery and the node surgery. So I think we complement with each other. But definitely endoscopist has taken achalasia cardia in a huge way and is one of the standard of care for the management of achalasia cardia. GERD, especially the hiatus hernia or the GERD, early mucosal malignancy in the GI tract, in the esophagus, in the stomach or in the colon, benign adenomas, some mucosal tumor, gastric outlet obstruction, not only endoscopically, but also endoscopic ultrasound guided, we are able to produce the gastrojejunostomy. Obstructive jaundice, both endoscopic as well as endoscopic ultrasound guided. Gastroparesis, we can do the G-POEM. Management of the obesity, which is coming up, the endoscopic sleeve gastroplasty is one of the tool where it fill the gap between the surgery versus the medical management. So I think there is a lot of crossover, and I'm going to talk first about the pancreatic fluid management, which I thought is very important. If you look at these photographs of the various pancreatic fluid collection, before Atlanta classification, these pancreatic fluid collections, the nomenclature was different as well as the treatment was different. Either it is an acute fluid collection or the chronic fluid collection, or the people say pancreatic abscess or people say pseudocyst. There was no terminology like walled off pancreatic necrosis. So these are the various fluid collection and they cannot be treated with the one standard methods. So the revised Atlanta classification had described the pancreatic fluid collection on the basis of necrosis. So around 85% of the patient have an interstitial pancreatitis that is called as mild pancreatitis. And if the fluid collection is less than 4 weeks, it is called as acute pancreatic or peripancreatic collection, which has no debris. And if they are more than 4 weeks, that is a mature wall formation, it is defined as pseudocyst. While in 15% of the cases when there is a acute necrotizing pancreatitis, and the fluid collection which is less than 4 week duration is called as acute necrotic fluid collection. They have got a lot of solid debris. And when they become walled off, that is called as walled off pancreatic necrosis. Why this differentiation is important? To differentiate, are you dealing with the pseudocyst or walled off pancreatic necrosis? Because the treatment success is different. The adverse outcome, the median length of the hospital stay, the cost involved, these all are different while managing with the pseudocyst or walled off pancreatic necrosis. The treatment success is very good with the pseudocyst. Adverse events are the less, quality of life and the median intervention required is less, and the length of hospitalization and the cost of treatment is less in comparison to walled off pancreatic necrosis. In another way, the prognosis is better with the pseudocyst in comparison to the walled off pancreatic necrosis. The line on the sand in the management of pancreatic fluid collection, the mortality should be single digit. We minimize unnecessary laparotomy or surgical necrosectomy, minimal procedure associated morbidity, no procedure related mortality or morbidity, and less pancreatic cutaneous fistulas. And I always feel treatment of pancreatic fluid collection is multidisciplinary, right from the surgical, interventional radiology, gastroenterologist, to the critical care. I think this is also one of the very important arms in the management of pancreatic fluid collection. The question comes, when to intervene in a pseudocyst or walled off pancreatic necrosis? The answer is, if the patient is symptomatic, either there is an infection or patient has a persistent symptoms in the form of luminal or biliary obstruction, persistent pain, failure to thrive, or one or cyst is increasing in size and at least of 4 week duration till the wall become mature. Now the question comes, in the endoscopic era, as a surgical colleague, majority of the time you have seen the endoscopists are doing with the side wing duodenoscope. But now, in 2021, the question comes, will you drain pancreatic fluid collection with the EUS or with the side wing duodenoscope? The answer is all pancreatic fluid collection, whether they have a bulge or there is no bulge. Important thing, 2/3 of the pancreatic fluid collection which is present in the body and tail of the pancreas, they don't have any bulge on the stomach or in the duodenum. Only the pancreatic fluid collection, which are present in the head and the neck of the pancreas, they produce a bulge in the stomach, unless until body and tail pseudocyst or walled or pancreatic necrosis is very large in size, they are going to produce the bulge. So earlier, the endoscopist, those who are the bulging lesion, they drain. The rest of the lesion, either they underwent the surgery or by the intervention radiologist. But with the help of endoscopic ultrasound, those pancreatic fluid collections with those who are near the lumen, either in the stomach or near the esophagus or in the duodenum, they can be treated very well with the help of endoscopic ultrasound. EUS allow the visualization of both the window of entry of the needle and intervening vessel. Even there is a small window of entry, if even there is a no bulge, and EUS can differentiate sometime the walled of pancreatic necrosis or pseudocyst from the cystic neoplasm of the pancreas. EUS give estimation of amount of solid debris and is very useful if patient has a compartmental portal hypertension. You can choose the window from where you puncture and you avoid the blood vessel. Important thing is, in the VON, the simple drainage is excellent for the pseudocyst, but it is sometime in around 50% of the cases, it is suboptimal. It requires an additional complementary drainage, either using the nasocystic catheter, which my colleague Dr.SUNDEEP LAKHTAKIA has a very good paper in the GI endoscopy, where using the step-up approach, he has used the nasocystic catheter and shown a very good results. Multiple transluminal gateway technique, direct endoscopic necrosectomy, using the metal stent, that is novel metal stent, dual modality of drainage, that is endoscopic, or percutaneous, or surgical with the percutaneous, endoscopic step-up approach. So VON generally, in around 30 to 40% of the cases, a simple drainage is sufficient, but they may require complementary procedure by these methods. So what lesson we have learned in the last 1 decade in the management of pancreatic fluid collection is open surgical necrosectomy has a significant morbidity, mortality, long-term fistulae, hernia, endocrine and exocrine insufficiencies. Now there is a paradigm shift. The people are moving more towards the minimally invasive technique. And I think timing of the intervention also an important, later is the better. So what is the current strategy in 2021 is step-up approach. And the rationale for using the step-up approach is a minimally invasive source control of the sepsis. And in the step 1, you only do the drainage. And drainage can be done either endoscopic or percutaneous. Around 40 to 45% of the patient, they become all right with the drainage, either you do endoscopic or percutaneous. But if patient is symptomatic or has a new onset of infection, then these patients require necrosectomy, and that can be done either through surgery from the percutaneous route or from the endoscopic route, through which you have produced a communication between the cyst and the gastric lumen. You can do the endoscopic necrosectomy, that is called as step-up approach. It is important for all of you to know that all pancreatic fluid collections cannot be managed endoscopically. There are the ideal patients are the VON or the cyst, which is situated in the lesser sac. This is the lesser sac and the stomach, which is compressing the stomach, which is centrally located, periluminal, and patient should be hemodynamically stable. If the patient is not hemodynamically stable, especially in the VON cases, I always feel we should avoid doing endoscopic, use percutaneous or surgical technique. That is a better way. So it is very important while doing the drainage of the VON or the pseudocyst, especially we talk about the VON, you should always choose the right patient for endoscopic management. Before doing endoscopic management, it is important you should have a cross-sectional imaging in the form of contrast CT or MRI to look for the pseudoaneurysm. You should have a backup of surgery or intervention radiology. You should have an adequate expertise of all three. Counseling about the other treatment option to the patient is very important. In pseudocyst, you put a 10 French or 7 French plastic stent, your job is over. But in necrotic fluid collections, These patients may require repeated procedures in the form of necrosectomy, or there is a crossover from endoscopy to surgery to the percutaneous. So you always discuss with the patient about the cost of treatment regarding the number of procedure, hospitalization, culture guided antibiotic, and one of the most important thing is CO2 is mandatory in these group of the patient. Don't use air as an endoscopic method because risk of air embolism. So I think for the pseudocyst, there is no confusion. Endoscopy is the treatment of choice. But for walled off pancreatic necrosis, still there is a lot of crossover. So these are the studies till 2007. After that, there is a 4 to 5 paper has come. And that shows endoscopy has a very good success rate ranging from 80 to 95% with the complication rate of 7 to 28%. And what is a game changer in the management of walled off pancreatic necrosis is presence of a SEMS. And we have an AGI stent, biflen stent, or Axios, and now we have a hot Axios. I just want to tell you those because most of you are surgeons. Hot Axios is a very good stent which has only single step procedure. You do the puncture with the same stent, you deploy the stent. While in the non-hot, that is non-hot stent, or in any metal stent or plastic stent, you have to do multiple procedure. Multiple means you have to puncture, you exchange with the guide wire, you do a tract dilatation with the needle knife or with the cautery, and then followed by the tract dilatation with the hurricane or CRE balloon, and followed by the stent deployment. So these are 4 to 5 steps which requires. With the help of hot Axios, you puncture, in the same session you deploy. So it is going to take 2 to 3 minutes. It is very safe, and it avoids the multiple steps which require for the drainage of the pseudocyst. The only drawback is it is a little bit costly around 1.5 lakhs rupees. Now the question comes, because there's a lot of debate going on, is the plastic stent is better or the metal stent is better? My opinion, I feel the metal stents are better. Large comparative studies between the metal and the plastic are lacking. But whatever the data available which says that metal stents are more efficacious because it is easier to deploy, shorter procedural duration associated with the low adverse event in the patient of Vaughan. You can do the endoscopic necrosectomy if you are using the metal stent. One distinct advantage of plastic stent is especially you can left these plastic stent for a longer time. Now, which stent endoprosthesis should be used? This is my take home. LAM has to be considered as a game changer. These stents are easy to deploy. I've already discussed. Direct endoscopic necrosectomy is possible. Initial experience with the LAMs are encouraging, but one of the paper from the Shyam Vardla Raju has shown that the LAM is associated with the complication, which I'm going to discuss later. But which stent and the endoprosthesis, this is the study in 2018. And what they shows that there was no significant difference in the total number of procedures performed with the plastic and the metal, treatment success, clinical adverse event, readmission, length of hospital stay, and the overall treatment cost between the two groups. Study also raised the concern, this is from the Shyam group, but if you look at the rest of the studies, I think the metal stents are preferable. This is my take home, but I would like to listen from my colleague, Dr. Sundeep also. The point raised from Shyam paper is you keep the lamp for 3 weeks and remove it. If there's still a cavity, you can put a plastic stent. Otherwise, you don't require to put any stent. Role of endoscopic transpapillary drainage in the Vaughan. This is very important, both for the pseudocyst and the Vaughan. Earlier, people, they were doing is, while removing the stent, they are doing the pancreatogram, or during the Vaughan treatment or the endoscopic pseudocyst treatment, they do the pancreatogram. I think now there's a good amount of data from Sundeep as well as from the Mumbai and from the All India Institute. 3 papers suggest that you don't require a transpapillary drainage when you treat the transmural drainage of the Vaughan or the pseudocyst. You are increasing the cost, you are increasing the chances of complication in the form pancreatitis. So there's no point in doing the transpapillary drainage of the Vaughan. The technique of doing this, if you have done the plastic stent, you dilate the tract, or if there's a metal stent, you can directly take a stent inside, you go inside the cavity and clean the cavity either with the snare or with the Dormia basket or with the Rothnet. So the plastic stent, you require a multiple time dilatation, while with the metal stent, you can again and again go. You don't require to do a CRE dilatation, and you can do the endoscopic necrosectomy. You can see these are the fluoroscopic image. My scope has gone into the right paracolic gutter, as well as you can go right from the body to the head of the pancreas. You can take your scope in and you can do the endoscopic necrosectomy. So these are the few videos where you are doing the Dormia basket to remove the necrotic material if it is indicated. If the patient is symptomatic, you can take your scope in using the CO2, and by using the various accessory, as I said, Dormia basket, rock net, snares, and especially the tripod is also coming where you can remove the necrotic material from the Vaughan cavity if it is required, and you can remove this such large chunk of the tissue. Now the question comes, which is very important, because all patients of Vaughan doesn't require a debridement. 30 to 55% of the patient can be treated successfully only with the drainage. Only around 40 to 45% of the patient, those who has a secondary infection or those who has an ongoing infection, they require endoscopic debridement. And which methods, as I said, people has used basket, snare, biopsy forceps, alligator forceps, or knot net. But there is no comparative study between these. It will be depend upon your preference. But if you ask me, it is better to avoid the biopsy forceps or the Dormia basket, because the wall of the Vaughan has multiple blood vessels running, and you may injure these vessels, and that may lead to the bleeding. What we have published our paper is, what I did is, I went inside the cavity and I flushed with around 1 liter of the normal saline. I don't do the necrosectomy. I don't scrap the wall. I just flush the fluid and clean the wall with the saline, and whatever the necrotic material which comes inside, I take out with the Dormia basket or with the rock net or with the snares. And in out of 64 patients, what we have seen is we were able to do it in around drainage and the necrosectomy in 62% of the cases, drainage with the PCD in 7.8% of the cases. Salvage surgery was required in 1 patient who has a persistent symptoms. Mean number of the session was 3.2. And the complications which we encountered was the major bleeding in 3 patients, minor bleeding in 3. And the major bleeding, what we encountered, all those patients where we kept the lamp for more than 3 weeks, patient turned up late, and that lamps, when the opposite walls fall on the lamp, it irritates the splenic artery and produces pseudoaneurysm. So the dictum is, you remove the lamps in 3 weeks time, the risk of the major bleeding will be less, and rest of the while doing the necrosectomy, you may come across with the minor bleeding, which can control by applying the hemoclip or by injecting the diluted epinephrine. So this, most of the time what happened is, necrotic material deposited on the stent, you have to dislodge it, and once you dislodge this necrotic material, the lot of pus will come out. Because, and to prevent this, now the concept has come, inside the metal stent you can put the plastic stent, so the necrotic debris is not going to block the inner flange of the metal stent. So that is the new advancement which has come while putting the metal stent in the patient of Vaughan. So when you compare the endoscopy versus surgery, so this is the trial by Bang, and what they have compared the endoscopy versus surgery in the randomized trial, and the primary composite endpoint, there is a significant less complications in the endoscopy group. And in the primary endpoint, they have included the new onset of organ failure, death, new onset of multiple systemic dysfunction, enterocutaneous fistula, visceral perforation, or intra-abdominal bleeding. And what they have seen in this study, the enteral pancreatic cutaneous fistula was significantly less in endoscopic group in comparison to surgical. Similarly, there is a tension trial. This was a randomized controlled trial of 98 patients from 25 Dutch hospitals. And what they have shown, that there was no difference in the primary outcome, meaning that there was no major complications or the death between the surgery or endoscopy. But the cost of treatment, the pancreatic fistula, day of hospitalization was significantly less in endoscopic group in comparison to surgery. Now the question comes, can we determine this patient will require drainage or this patients require the endoscopic necrosectomy? Yes, this is a paper from Surinder Rana from PGI, and what he has shown, if patient has more than 40% necrotic material in the wound, then you should talk to the patient. The chances of doing the necrosectomy will be very high. If the necrotic material is less than 40%, there's a possibility that these patients can only be managed with the drainage alone. So when is the necrosectomy indicated? When more than 40% necrotic debris or non-resolving symptom or persistent wound. Impact of wound I have already discussed, that if you keep the wound for more than 3 weeks, the chances of bleeding are more. This is a paper from the sham group. And now the concept is you keep the lamp for 3 weeks, you remove, if still there's a cavity, you put a plastic stent. If patient has this kind of collection, that is in the lesser sac as well as in the paracolic gutter, it is better to use the dual methods. The lesser sac can be treated with endoscopic ultrasound, and paracolic gutter can be treated with the percutaneous method. This is a paper from the All India Institute. What they have done from the percutaneous route, they dilate with the CRE balloon and they take the endoscope through this and they did the necrosectomy. This was published in 15 papers in clinical endoscopy, and 14 improve after a mean session of 5 sessions. So that is also one of the alternative method. You don't require to do the surgery. Combined drainage, I said there is any benefit of doing the transpapillary drainage. You don't require to do the ERCP in these patients. Now the last few slides, can we predict the failure of endoscopic treatment? Yes. If patient is obese, peripherally located wound, extension into the paracolic gutter, or there's a history of diabetes prior to that, then these patients, history of diabetes or size of the wound, poor medical health, these patients may have poor outcome with endoscopy. When not to intervene with endoscopy, asymptomatic patients, paracolic gutter extension, multiple collaterals, distance between the wall and the stomach wall is more than 1 centimeter. If the wall is immature, that is very important. Multiple collection if the patient is hemodynamically stable. So what is the need of our is which patient is suitable for surgery or endoscopy, that we have to decide. If we can decide this patient is suitable for endoscopy or this patient is suitable for surgery, then we can do the personalized treatment. Tailor-made intervention is the need of an hour. Now the complications when we talk, the mild bleeding can be managed, but the major bleeding requires interventional radiologist. So the presence of the interventional radiologist is very important. This is a branch of the gastroduodenal artery which has an aneurysm, and these patients bleed during that time. Our interventional radiologist put the coil and the glue, and the bleeding was stopped. So presence of the interventional gastroenterologist is very important. Sometimes you may come across the bleeding while puncturing. This could be because of the intervening vessel. This is important. Those who are doing the endoscopic ultrasound, they make sure that there should not be an intervening vessel. This is one of my video. While puncturing, I have not put a Doppler, and the vessel was going between the cyst and the gut wall. You see, this is the Doppler signals, and my needle was going through it and patient was bleeding. I stopped the procedure rather than proceeding with the procedure. So this is important, that if the bleeding happens, don't continue with the procedure, because this wound is a closed cavity. Bleeding will happen in the cavity, and the cavity itself will produce a tamponade, and the bleeding is going to stop. Delayed bleeding, I have already spoken. When the LAMS is for more than 3 weeks, it impinges on the splenic artery and it can produce the pseudoaneurysm, and it may require the bleeding and read of interventional radiologist. Sometime you may come across the perforation, then we definitely require our surgical colleague. Separation of the cavity, if there is no connection, good maturity between the cyst and the stomach wall, there is no adhesion. While doing this dilatation, the cyst cavity separate, and during that time, the entire fluid can leak into the peritoneal cavity. In that case, it is important, you should hurriedly put the metal stent. You look at here, when the cyst cavity is separate, so this is the cyst, this is the stent which has bulged between the cyst as well as in the stomach wall, and it was a rapid metal stent was placed and we were able to salvage. Otherwise, this patient would have been requiring a surgery. Migration is one of the complications. It can be inward migration into the cyst cavity that can be taken out with the endoscopy, and you can readjust the stent and it goes to the lumen. most of the time it come in the motion. So migration can happen. This is one of my patient has a gastric outlet obstruction. We just removed the metal stent and patient was all right. You see the CT, the stomach was full of the gastric content, and this is a duodenum which produces the gastric outlet obstruction. This is an endoscopic view. You see the stent has impinged on the opposite wall and produce the gastric outlet obstruction. So ladies and gentlemen, to conclude for this talk, I think endoscopic necrosectomy is safe and effective treatment in selected group of the patient, not in all. No single approach is effective. We should individualize the scope. Is a time-consuming necrosectomy, labor-intensive procedure. Patient and the physician tolerance is very important. I think SAMs are better. Endoscopic necrosectomy procedure is still evolving. Additional advancement are still awaited. So I'm going to talk about the second talk, that is the poem. So I will reshare my slides.
Thank you, Rajesh. I think that was nice. I think while you preparing your screen, you can keep sharing a slide. I just wanted to tell the audience that we will take the questions and answers in the end. There are some questions which have surfaced in the chat box, but to make the whole session more efficient, we will take it in the end of all the three parts which Rajesh has divided the talks into, since it's a very broad topic, as I said in the beginning. Okay, Rajesh, please go ahead.
I'm just hiding because it is.
Yeah, meanwhile, keep posting your questions. I'm seeing some of the questions which have come there. Neha Chaudhary has posted, Dr. Jitendra Chauhan has posted. We will take these questions in the end one by one. We can see your slide, Rajesh.
Yeah, I'm just actually the entire screen is coming with the
Okay.
panelist. So I'm just a little bit adjusting so I can do the things. Okay, so I'm going to talk about the third space endoscopy, that is per oral endoscopic myotomy procedure, how I do it. So I'm going to discuss this presentation. What are the clear indication of POEM? What are the contraindication of POEM? What should be the pre-operative and the OT preparation before starting the procedure? Technique step by step, common pitfall and take-home points. So originally POEM was meant for the type 2 achalasia, but in the last 6 to 7 years, the emerging evidence shows all achalasia type at all ages, POEM is the standard of care. I know that a lot of questions will come from the surgeons. Pediatric achalasia, spastic disorder of the esophagus, I think the POEM is the treatment of choice. In a failed surgical procedure, the redo procedure, or in the failed POEM procedure, you can do the anterior or the posterior if you have done with other methods in the first. So I think POEM is the standard of care now. But it is very important for the beginners to understand the contraindication of the procedure. A patient has a severe cardiorespiratory disease. Pseudoachalasia is very important to understand. I will give a recent example. Patient was after my life to do the POEM. He was referred from, he was coming from the another hospital where he was advised POEM. And while doing the manometry study, we realized that he might have a secondary achalasia. We did a CT scan, he has a large thymoma. And patient was still after our life that you please do this because my wife cannot eat and I can do the thymoma surgery later. But we insisted that thymoma can also produce the secondary achalasia. We did a thymoma surgery and 3 days before we did the manometry and this patient has no evidence of achalasia. So this is very important to rule out pseudoachalasia while treating, because as an endoscopist, we are very much fascinated about doing the endoscopic procedure, but pre-operative workup is very important. Another contraindication is failure to create a submucosal tunnel because of the fibrosis, or patient has a severe esophagitis, that is a relative contraindication. You can postpone the procedure and you can do later on. The pre-operative preparation is very important. Pre-operative investigation in the form of endoscopy, barium, and the manometry studies are mandatory. Keep the patient in the liquid diet for 48 hours, otherwise a lot of solid food will be present in the esophagus. Treat esophageal candidiasis in before. So what I always do in my practice, I generally do the manometry studies and endoscopy 4 to 5 days prior to the POEM procedure. At least I should know the status rather than posting the patient, intubating the patient, and you take the scope in and you know that there is a severe esophagitis, ulcerations because of the stasis, or there is a candidiasis, and you extubate and tell the patient it's not possible, you have to come after 2 or 3 weeks. So do a pre-operative workup 4 to 5 days before, rather than patient comes with a 2 months old report and you directly take for the patient for the POEM. I keep the patient nail by about at a night before. In case of sigmoid esophagus, it is better to keep the patient on the liquid diet for a longer period of time, and detail past treatment in the form of dilatation, botulism injection, previous history of achalasia treatment is very important. Before going for the procedure, it is important your technician as well as your doctor always has a checklist. And what is the checklist? Patient should have a PAC workup. Endoscopy shoot with the CO2. Air is contraindicated. This is very important. You all should know the CO2 facility should be there. High definition endoscope, which has a water jet facilities, is important. Electrocautery machine, either RB 200 or 300D. RB jet or Olympus jet, water injection is important. Diluted methylene blue or indigo carmine is important. Cap distal attachment, either a narrow or void, is also important. Hybrid knife or Olympus TT or TTJ knife is important. Co-grasper for control of the bleeding, hemoclip, and the pre-procedural antibiotic. But now the data is emerging, you don't require antibiotics also. The equipment needed is Olympus CO2 insufflator, the low flow oxygen 1.2 liter per minute. And the most important thing is always switch off. This slide, if you see, always switch off the air. Sometimes you on the CO2, but you forgot to close the air. So O2 and air both will go. It is important that you should switch off the air button on the endoscopic system. That is important. The equipment, as I said, you require a high definition gastroscope with a cap with a 2.8 millimeter channel. You require injection needles with the methylene blue, hemostatic accessory co-grasper. You require hemoclip, and you require the water jet facilities. These are the equipment which is functioning. It is very important. Commonly used knife is hybrid T knife or Olympus TT or TTJ knife, or the speedboat is coming. The difference between the hybrid knife and the TTJ knife, the hybrid knife is from RB and the TT or TTJ knife is from the Olympus. That is, the mucosal injection can be done with the hybrid knife. You don't require a separate needle. Rest of the procedure like mucosectomy, submucosal dissection, myotomy, and hemostasis can be done by both the knife. Cautery setting is very important. And I think now most of the machines has a prefix setting. So you should not worry, I think. This is because earlier people was very much worried about what should be the setting. But now there are the prefix setting on the machines, POEM, ESD setting. And generally what I do in my practice is I always use the endocut Q. But yes, with the Olympus, people use the endocut Q or spray coagulation. And for bleeding, for the minor bleeding, you use the force coagulation. For the major bleeding, you use the soft coagulation. And with the TT knife, you can use the spray coagulation. In my practice, I use the endocut Q, which has both spray as well as cutting. So you help in preventing the bleeding from the small vessels. The steps of the POEM procedure is understanding the anatomy, choosing the best site of injections, entering the tunnel, creating the submucosal tunnel, myotomy, closure, and tackling the adverse event. What should be the patient position? This is a very frequently asked question. I always keep my patient in the supine. Although there is no data to differentiate which is better, supine, lateral, or the prone position. But supine is universal because it is good for the anesthesia. It is good for your assistant to watch for any CO2 related complication in the form of capnoperitoneum. And in supine position, scope in the resting position, and the curvature of the esophagus, because in the supine position, because of the gravity, the curvature of the esophagus hardly make any difference. So I think supine is always a better position. Now, as I said, it is important to do the mapping endoscopy. You clean the esophagus, saliva, or the food residue. The posteriorly, this is the spine, because you can do with the anterior approach or with the posterior approach. And how to identify that which is the anterior or posterior. The spine is a very good landmark, or you can put the water. Once you put the water, where the water is stagnant, that indicate you are in the posterior position. Do a complete endoscopy, took a retroflex view to look for any chances of secondary achalasia, clean the stomach with the water, remove all food residue, and clean the esophagus by putting lot of water. There should not be any food residue. Look the esophagus for the stasis, severe esophagitis, or for the ulcerations. Once you have done the mapping endoscopy, the second come about the injection. So the spine is posteriorly. For anterior, you have to inject at 2 o'clock. This is the 2 o'clock position for the anterior poem. This is the spine where you should not inject. You inject around 5 o'clock position, that is a posterior. And as I said, you put the water where the water is stagnant, that indicate you are in the posterior route. You introduce the needle with the jabbing movement, withdraw the needle, tell your technician to inject the diluted indigo carmine or methylene blue, and inject around 10 ml of the normal saline to raise the very good blab. And once you are able to raise the good blab, the second step come about the incision. There are certain positions when there is a severe esophagitis, patient have a lot of fibrosis and you are not able to inject, you are not able to get a good blab. What should you do? You go a little bit more down, or change your place, or go to the anterior route. And even after that you are not able to do it, it is better to postpone the procedure, put the Ryle's tube, keep the patient on the feeding for a few weeks, and then try. And even after that you are not able to do it, it is better to subject the patient for the surgical intervention. Incision, you give around 1.5 to 2 centimeter of the incision. Incision can be given from distal to proximal site or from proximal to distal. And it is important that your scope should move rather than your knife should move. People has a tendency to put the knife and then withdraw it. Then you are not able to remain in the continuity. And once you have given the incision, the second aspect is you have to do the dissection on the margins as well as the front of the incision site to enter into the submucosal tunnel. This is the very crucial step, because beginner give the incision and they keep on introducing the cap inside. And once you try to keep on introducing the cap inside, you are going to increase the size of the incision. So it is important on both the sides of the wall of the incision side, you do a good dissection, as well as on the anterior side, to help you to go in the submucosal space rather than pushing with your cap to increase the size of the incision. That is very important. And entering into the tunnel, this is the trick which I said. You do a dissection on the side, on the edges of the incision side, on both the sides as well as on the front. So you look at both the video where there was a mistake done in the first video, and this is the right, where I'm incising on both the edges of the incision site to create the space for my scope to go in. So I'm cutting on the side to the submucosa. On the left side I cut, now I'm doing on the right side. Then I will do on the anteriorly at the side. So you create a good dissection on both the margins of the incision side. And once you have created a good space, now this is the anterior side where I'm doing. Now you have created a space and you can go into the tunnel very easily. Now you see my scope with the cap is going in and I am into the tunnel. So this is the way you should go. Spend few minutes, clean both the margins of the incision side, clean the anterior front side, and then go into the submucosal. Don't try to keep your cap and the scope to push in, otherwise you are going to increase the incision site and that is going to create a problem. Once you have entered into the tunnel, the second is submucosal tunneling. And the concept is maintain the orientation of the scope. Dissection plane should be between the muscle and the submucosa. The muscle is at 6 o'clock position. You see, this is the muscle. The above is the submucosa. I am cutting between the muscle and the submucosa rather than between the submucosa and the mucosa. So your first above layer will be the mucosa, then submucosa, and then there is a muscle. So you cut between the submucosa and the muscle. Even there is a small amount of injury to the muscle, there is no problem because you are going to cut the muscle. Keep the submucosa up towards the mucosa. So there will be a cushion. Otherwise, the chances of the mucosal injury will be very high. And avoid the blunt dissection. As a beginner, people has a lot of tendency to push with the cap of the scope. What is going to happen when you push and you do the blunt dissection? The small vessel will stretch and they start going to bleed. So the two important point of submucosal tunneling is always your scope should be perpendicular to the muscle, number one. Number second, the dissection plane between the submucosa and the muscle. You can injure the muscle, that is not a problem, but you should not injure the mucosa. That is the most important thing. Now, tunneling at the G junction is very important. I think I've shown the previous video. Yes. Now, once you reach to the G junction, the tunneling at the G junction is very important because there is a spasm. There might be a fibrosis because of dilatation. That space is narrow and there's a high chances you are going to injure the mucosa. So always keep your patience. Swift and the slow, precise dissection is important. Repeated injection to the submucosa is mandatory. Identify muscle because splitting is possible. So avoid splitting at the G junction. Cleave close to the muscle. The key is slow, precise, and repeated injection into the submucosa. If dissection is not possible, then it is better to do the cut the muscle rather than producing the injury to the submucosa. Go a little bit through the muscle, and then once you reach to the stomach, then you again started doing between the submucosa and the muscle. Now the question comes important, how to identify that you have reached to the G junction? Because in achalasia, there is a dilatation of the scope. Sometimes the scope buckle, and the marking which you have seen that G junction is at 40, your scope is buckle into the submucosal plane and you are not very sure that you are at G junction or not. So depth of the incisor from the incisor is not the 100% marker. Resistance to the scope at the G junction is one of the marker. Identification of the palisade vessels. On the mucosal side, you find the palisade vessels and you will find the spindle vein that is on the muscle side. That is another marker. Perforating vessels. You may find the perforating vessels on this side, which indicate you find the first perforator and the second perforator. And if you take another scope and retroflux, you can see the light into the stomach. So these are the 5 or 6 points from which you can identify that you have goes up to the G junction. You have to go at least 2 to 3 centimeters distal to the G junction to the stomach. Once you have done, then you go to the myotomy. The few important points about the myotomy. The myotomy should be started at least 2 centimeters distal to the G junction, distal to your incision site. Where you have given the incision, 2 centimeters distal to that, you start myotomy. Now the question comes, do you do a circular myotomy or longitudinal myotomy or both? So the people has done the circular myotomy in the beginning, and just above the G junction, you do the circular as well as longitudinal myotomy. But the data is emerging because longitudinal muscle fiber, they are soft, they are thin, and they are sparse. So they separate. So if you look at the literature, there's no difference. Even you do a complete myotomy or you do initial circular followed by the complete myotomy, it hardly make a difference. Now the concept is the length of myotomy, that is important. The data is emerging, the 2 to 3 centimeter proximal to the G junction and 2 to 3 centimeter distal to the G junction is sufficient rather than doing the long myotomy. Which cases you require a more long myotomy, it will be decided on the manometry finding. If there's a long segment of the spastic segment, you do a long myotomy. Especially in type 3 achalasia or jackhammer esophagus, you'd require a long myotomy. But the important thing is, once you have done the myotomy, look for the vessels. You see, we have done the long myotomy. Look at any visible vessel which has either bleeding or chances of bleeding. Coagulate with the co-grasper or with your hybrid knife or with the TTJ knife, make sure that you have achieved the hemostasis before closing the mucosal gap. Now, how to close? The first clip should be at the proximal side of the incision, where the both sides of the mucosa come close. You take your clip close to that, hold both the side of mucosa equally, make your big knob away, do a suction movement in the open clip, the mucosa will come in, and then your technician to tell that he should apply the clip. So this is a little bit a tricky situation, but those who are doing the regular endoscopy, they know that how to do it. I always say this is called as kalmi sign, like a kalam. So your clip should be like that. You apply first distal to the incision side proximally, taking both the side of the mucosa on the equal side, apply the clip by doing the suction movement, and then using 4 to 5 clip, you are able to do the complete closure. Once you have closed, keep the patient NPO for 24 hours. You give patient IV analgesia, antibiotic, and PPI. Antiemetic can be given if it is required. We generally do the oral gastrography in 24 hours, but the paper is coming on the same day. People do the gastrography and discharge the patient on the same day. PPI should be continue at least for 2 to 3 months because risk of reflux is there. I know as a surgical colleague, lot of questions will come for the reflux related issues. The F poem, the people has used the endoscopic fundoplication, but I think the lot of data needs to come out to say that yes, while doing the poem, you can do the fundoplication. We generally keep the patient liquid diet for 5 days, oral antibiotic on discharge, manometry and upper GI at 3-month interval. Mucosal injuries are important. This is, I think, few slides are important. Don't go across the G junction multiple times because G junction is tight, and when you go with the cap, you may able to injure the mucosa at the G junction side. Remain close to the muscle. I have told the dissection should be between the submucosa and the muscle. Submucosa should be lifted towards the mucosa. That is important. Be careful if there's a significant fibrosis. If there's a significant fibrosis, always keep your knife towards the muscle. Again and again, I'm saying you can injure the muscle, but don't try to injure the mucosa. Prevent recurrent buckling of the scope because it is going to increase the size of incision. Type A injury where there's a little bit of the burn, you don't require to do anything, but if there's a gap, then it is important you should close first mucosal injury and then proceed with the later dissection. These are the video of mucosal injuries. Shaft related injury, you see the fluoroscopically, the shaft of the scope is buckling in the sigmoid esophagus and increasing the length of the incision. So that is very important while doing the procedure. You should not increase don't produce the buckling of the scope. That should be kept in the mind. The bleeding related complication, always keep the clear working space by putting the water jet. Localize the bleeding by putting a water jet. You should know from where the bleeding is coming. If the bleeding is coming from mucosa, it is important for you that if you try to coagulate, you can injure the mucosa. Use the co-grasper, pull towards you, and then do the force coagulation, and that will prevent the bleeding. That will prevent the injury to the mucosa. And if there is a major vessel, then use the co-grasper to prevent the bleeding rather than using your knife. And using the soft coagulation, you can make sure that you have done the complete coagulation of the vessel and you can proceed. And if the bleeding happens during the procedure, then as I said, you put the pulse. So this is the bleeding happened. We put the water jet and hold. Or you apply the pressure with the cap till your accessories is coming. And once your accessory is out, then you can use the co-grasper using the soft coagulation. You can achieve the hemostasis. So water jet is very important. And before releasing the hemograsper, taking out into the scope, make sure that you put more water to make sure that the patient is not having a ongoing bleeding. So use the soft coagulation and make sure that you have achieved the hemostasis. You may come across with the CO2 related complication in the form of capnoperitoneum. So that is important. Your assistant keep on looking at the abdomen, or if there is a compromise in the ventilating the patients, your anesthesia people is going to tell, then you can put the 16G cannula and you can remove the capnoperitoneum and you can continue with the procedure. That is going to help you for continuation of the procedure. OM variant in the difficult cases, tunnel creation is the key point, and for tunnel creation, the answer is inject, inject, and inject. Multiple knives may be used, IT2 knife or hook knife in cases of fibrosis. Using the cutting current rather than coagulation current is important. Stay close to the muscle, low threshold for peritoneal decompression. Clip any mucosal breeze, and large defect may require suture or the stent. So I think rest of the things, sigmoid is one of the things which I said, always make sure that patient should not have any ulcers, or if there's a sigmoid esophagus, you can use the wire technique rather than looping your scope, because sometimes in the tunnel you loop your scope and you are not able to go. So wire and the fluoroscopy is able to guide you that what is the direction of your, in the redo posterior myotomy, it is better you, in the cases of surgical, you do a posterior approach, that will be better. So my experience, patient want a good procedure. It is not the race. Time is not an important. You give a good and the proper treatment to the patients. Endoscopy should take care of himself, take care of his back and the neck, because these are the long duration procedure. Do careful, do a safe, precise and deliberate dissection. Keep your head clear, anticipate the problem and ready to tackle them. You should know about your accessories. Take your time and get comfortable with your knife. It is a team approach. Thank you. So the last talk, I think 1 hour is over.
Thank you, Rajesh. That was nice.
So
Quite
I will
elaborate.
just briefly mention Dr. Sundeep.
Yes, Rajesh, thank you. Yes, I'm observing.
You are not audible, Dr. Sundeep.
Yes. Time is being observed, and also the talks are very nice and lucid and quite self-explanatory. A lot of doubts which people have in the early days.
Dr. Sundeep, you are not audible.
Can you hear me now?
Can you switch on your audio?
Can you hear me now? Hello? Hello?
Yeah.
Can you hear me? If my audio is on.
Yeah, we can hear.
Okay. Thank you, Rajesh. That was nice and lucid talk on third space.
Some more.
I can't hear you, Dr. Sundeep. I may not be able to hear you at all.
Dr. Puneet just mentioned that he's able to hear me. So there may be some issues in your laptop.
I can't. Can you hear me?
I can hear you.
But I can't hear you.
Anyway.
It is the problem with the device of Dr. Rajesh.
Dr. Baju, can you hear me?
Yeah, I can hear you.
Okay. So anyway, if others can, Anjali also just.
Am I audible?
Yes, you are. You can hear me now, Rajesh?
I can't hear you at all.
Okay.
Dr. Rajesh,
should I rejoin it? Last time it happens.
Yeah, I think some problem with your device.
Okay. So for the audience, both are audible, as Anjali Davle has just mentioned. And thank you, Anjali, for updating us. This makes it very clear cut. Rajesh gave a very nice talk on 2 different aspects of endoscopic treatment, which overlap the surgical treatment.
Rajesh, can you go out and come again? I think you co-host.
I can hear now.
Okay, good.
Okay, no problem.
Okay, so let's move forward now. And once we have the third topic of today's discussion get over, then we will take the questions and answers.
So I think the refractive guard is always be a domain of the surgeons until now. But now we have a Gardex device, which is very useful in the health classification 1 and 2. Yes, patient with the large hiatus hernia, this is not the standard of care. But patient with the Hills 1 and 2, we can do the endoscopic fundoplication using the Gardex. And this is, you see, these are the 2 arms of the Gardex, which is the having a stitches. This is the rotator which goes inside the mucosa reaches up to the muscle layer, and you retract it between the two arms of the Gerdex device. And you can apply on the grid on the lesser curvature. So this is full thickness sutures you are applying from serosa endos, from mucosa to the serosa to the mucosa. And you can apply 2 to 3 sutures to give an excellent result, as our surgical colleagues doing for the hiatus hernia. So this is the first stitch which has been applied. So this device is a disposable device which you use, which has 2 arms and the sutures are loaded over them. And between 3 o'clock to the 9 o'clock, you apply 2 or 3 sutures depending upon the needs. But the most important thing is it is useful in a patient who is PPI responder with the Hills grade 1 and 2. It is not a very good modality for Hills grade 3 or patient who has a large hiatus hernia. This device has a channel for a thin endoscope. So this is one of the retroverted scope which is giving the view, and this is the device which go over the wire. You remove the wire and you retroflux into the fundus. So this is the device, and endoscope is on the side of this device to give the complete endoscopic view. And you can do the 2 to 3 plication depending upon the needs. And this entire procedure is going to require half an hour to 45 minutes. And patient can be discharged on the same day. So once you apply the clips, you remove the device, and you can see the retroverted view. The G junction is completely closed, and that gave a very good results. And if you look at the result, so there's a very good satisfaction score. I don't know why it does not. And another procedure is the arms procedure. What you do in the arms procedure is you do the endoscopic mucosectomy at the G junction, and because of this you remove the mucosa and the part of the submucosa, and when it heals with the fibrosis, it increases the angle of His. So first you inject in the retroverted view with the diluted methylene blue or with the indigo carmine, and then you do the snare mucosectomy on the lesser curvature, and you do 3 to 4 mucosectomy and do around 3/4 of the G junction mucosectomy. And when this heals, that produce a very good results in a patient of GERD. But this require more data to say that this is a very good method. The literature is less, but this is a device which is cheaper, can be done by the endoscopic without much of the cost. The only problem is sometimes the patient bleeds and you have to take care of the bleeding point. So if you look at this paper from the AIG, the endoscopic full thickness plication for the treatment of PPI, the quality of life was much better in 65% of the patient in comparison to the sham group. So endoscopic Gerdex device is useful in Hill's classification 1 and 2. Esophageal diverticulum, that is the Jenkins diverticulum, the JED poem. Now the good amount of data available to say that JED poem is safe. visible in the Jenkins diverticulum. This is the video. Barium shows a 3 centimeter size Jenkins. This is the endoscopy. This is the diverticulum. This is the septum. And this is the esophageal lumen. It is the same as doing the poem. Around a centimeter proximal to diverticulum, you inject, raise the blab as you have done in the poem procedure, give 1 to 1.5 centimeter or 2 centimeter of the incision. Again, clean both the sides to make sure that your entry into the tunnel will be easier. So I am clearing both the sides of the tunnel. And once you are clear both the side of the incision, you go inside the tunnel. Then on both the side of the septum, you do the submucosal dissection as you have done in the poem, both on the septum side as well as toward the esophageal lumen. And once you have done, then you do the septotomy. Earlier, the people was doing endoscopic septotomy, but the recurrence rate was very high, up to the tune of 18 to 20%. But with this, the success rate is very good because you can go up to the base of septum. Even if there's a small perforation, you can clip the mucosal incision which you have done. So endoscopic septotomy can be done till the base. And if any bleeding happens, you can use the co-grasper to stop the bleeding. So you know that we are reaching up to the base of the septum. We have reached up to the base of the septum. The complete septotomy was done. And once you do the complete septotomy, you see that you have reached up to the base of the septum. And once you do the complete septotomy, you can close the incision site with the clip. So jet poem, I think in the future will be the standard of care, is going to require not more than 30 minutes. And it gives the excellent result with the very less chances of recurrence of the symptoms. This is the clip closure of the incision site which has been made. And you can check after 24 hours with the gastrographin study. If there is no leak, you can tell the patient to start with the liquid diet for the 5 days. Similarly, achalasia cardia, I think I've discussed, which I'm not going to talk more. I will. Refractory gastroparesis, surgical gastrojejunostomy is standard of choice. But now you can do the endoscopic incision of the pyloric ring as well as stomach, especially the gastroparesis happen after the post-surgery where the vagus nerve injured, but it is also useful in the adaptive gastroparesis patient. The good amount of data available and which favors about the endoscopic treatment of gastroparesis. This is the video. You can see the spastic pyloric ring. Difficult to take the scope in. Earlier, people has used the botulinism also in this. You give a mucosal injection of diluted methylene blue or indigo carbene 4 centimeter proximal to the pyloric ring into the stomach. Give a longitudinal incision or give the horizontal incision. This will be your preference, but in my practice, I do the horizontal incision. This is one of the video where we did the perpendicular incision. You go into the submucosal space. Again, do the tunneling between the submucosa and the muscle and reach up to the pyloric ring. The most important point in this is once you reach to the stomach, you see we are into the duodenum here. This is the pyloric ring, I suppose. I think still we have not reached. The most important as you are doing in the poem or in the Jenkins diverticulum, you do the submucosal tunneling, go up to the pyloric ring, and distal to that up to the initial part of the duodenum. Once you reach there, then do the incision of the pyloric ring and 2 centimeters into the stomach. So you see, this is the pyloric ring. This is the duodenum. Now you do the incision of the pyloric ring and 2 centimeters into the stomach. And once you have done the myotomy, you close the incision site as you are doing in the poem. And after 24 hours, you can do the gastrographin study. The best result in the post-surgical cases, but it can be useful in the diabetic patients. But it is important, you should always make sure that this patient has a documented gastroparesis, do the scintigraphic study, keep the patient for nil for 24 hours, and if the patient still has the food residue, so clinical, endoscopic, as well as scintigraphy studies are important before going for this. Enteral anastomosis was always be a surgical domain. Now the gastric outlet obstruction has been initially treated with the endoscopic stenting. I still feel it is still the treatment of choice. But some patients who has a longer life, these patients may require a multiple enteral stent. In those situations, you can do the EUS-guided gastrojejunostomy. There was no surgical difference in the technique or the clinical success, symptoms, recurrence, or reintervention. No difference in 30 days readmission or 30 days mortality between the EUS-GJ and endoscopic guided gastrojejunostomy. EUS-GJ patient experienced shorter delay in comparison to surgery and had a shorter length of the hospitalization and reduced hospital cost in comparison to surgery. And how we do EUS guided? There's a dedicated tubes, but which is not available in India. It is available in the Japan, but in our country, what we do, we put a nasobiliary drain, put the contrast into the jejunum distal to the DJ flexor. We put around 200 to 300 ml of the water. And once the jejunal loops are visible, we take our EUS scope. These are the dilated jejunal loops. And this is a hot axios, which has punctured from the stomach to the jejunal loop, which is very close to the stomach wall. You deploy the proximal flange. And once you deploy the proximal flange, pull it. So hot axios has a separate delivery system. You have to understand locking and unlocking, which is not possible for me to discuss now, but we have released the proximal flange. Now the second flange generally dislodge in the endoscopic channel, and then you can push it. And once you have done the gastrojejunostomy, you can dilate the tract with the CRE balloon with a 12 millimeter. So this is a hot axios. Wire is still inside. We dilate with the CRE balloon up to the 12 millimeter, and we can go into the jejunum. So you have created a neo space, which is chances of stent in growth is not there. And this has a reasonably very good success rate and the long-term patency. So this is the EUS guided gastrojejunostomy. Endoscopic management of the submucosal lesion. It prevents the morbid surgery. Although the laparoscopic surgeries are very good, because my feeling is still this is more prevalent in the China, but yes, in a near future, this will also take a lot of chunk from the surgical colleague. This is a 2 centimeter gist. You do the marking. and do the ESD. Do a circular incision because the gist is arising from the fourth layer, so you are bound to have a perforation while removing the gist tumor. So you do the submucosal dissection using the hybrid knife or TTJ knife or the hook knife or the IT knife. So this is, we are doing the submucosal dissection. This is the muscle side. We have done the near complete submucosal dissection. The remaining is the tumor. This you saw while removing the tumor from the muscle, there is a perforation. So once you do, this is a tumor which removed from the muscle side. This is a gist tumor. Now you require to close the incision side. First, we are using the dental floss to raise. And once you have taken it out, the complete tumor, so this is the final cut, and you can see the omentum has come in. So there was a complete perforation into the stomach. Now this can be closed by various methods. It can be closed by Ovesco. This can be closed by the bursting suture using the multiple clips with the snare, or this can be clipped by the endoswitcher, Apollo endoswitch. I have no experience of Apollo endoswitch and the endoswitcher, but yes, snare and the clips method is very good. You put a snare around the perforated side and apply the multiple clips. And then when you tighten the snares, that give a complete closure. That is a loop and the clip method that is called as loop and clip method. And this is the EFTR, or full thickness resection of the gist tumor. So this was a gist. The stir procedure, especially the esophageal leiomyoma, you do a blab 5 to 7 centimeter proximal to the esophageal leiomyoma, give an incision, same like the POEM procedure, to 2 centimeter or so, because it will be easy for you to take inside. This is completely same as a POEM procedure. And you do the dissection, and once you reach up to the submucosal tumor, which started appearing the whitish leiomyoma, you are doing the submucosal dissection. You see here the leiomyoma started appearing. The tricky point in this is, while doing the dissection between the mucosa and the leiomyoma, this is a crucial, you may damage the mucosa, that you have to take care. And the best part is you keep on doing the submucosal injection. Taking out the leiomyoma from the muscle is not a problem. You can do the muscle injury, or you can cut the muscle. That is not a problem, because you are going to close the clip. So what is most important in leiomyoma, the stir procedure, is the dissection between the mucosa and the leiomyoma. That use the knife. That is the you always try to use the knife which has an insulated tip. Do a submucosal injection to raise the blab, so chances of injury to the mucosa is less. And I always try to use the cutting current rather than the coagulation current, to make sure that yes, injury to the mucosa is less. Now resection from the muscle is not a problem. And once you have done using the rock net, you can take it out completely. Sometimes these lesions are bigger, but yes, up to the 4 to 5 centimeter, it is possible to remove these tumors. ESD and EMR of the T1, T2 malignancy. I think this is the same principle. So this is a rectal T1 lesion. So we have done around 6 or 7 days before 8 centimeter rectal lesion, which is complete encircling. This is one of the video of T1 large rectal villus adenoma. This is a retroverted view. you do a same principle of the ESD. You remove completely, you do the complete resection. So ESD of the T1 lesion of the rectum, and you are able to remove completely. You do the submucosal dissection. The most important thing in the colon is a rounded. So you should know the muscle, how the muscles are moving. That is very important. Otherwise, you are going to produce a perforation. So this is the complete removal of the T1 lesion in the rectum, which is possible endoscopically. Esophageal, same. I'm omitting this because of the lack of time. Yes, endoscopic closure of the perforation in the fistula, which is very important, which is important while doing endoscopic procedure. If you have a perforation, you can close it. So this is few days before we have removed the neuroendocrine tumor from the first part of the duodenum. This is the neuroendocrine tumor from the first part of the duodenum. We are using the Ovesco clip. Just give me a second. Okay, but this is the one of the video. Actually, I don't know why it's not running, but this is the Ovesco clip. We have done the NET of the first part of the duodenum, and we did the endoscopic cap resection by applying the EVL methods. We apply the band, and then we did the endocut Q, and there's a perforation in the first part of the duodenum. This video is not running, but we're using this is the video you can see. We apply the Ovesco clip and the patient, the complete closure was done. Endoscopic oversight closure of the perforation is possible. So this is a Apollo overstitch device. First try to close with the clip, but it was not possible. With the Apollo switch, you can apply the switcher. So even a larger perforation of 4 centimeter or 3 centimeter can be very well taken with the overstitch closure using the Apollo endoswitch device. So this is one of the video, but I don't have experience about this, frankly speaking. Similarly, the endoscopic closure of the fistula is also possible. Same with the device, Apollo device. The fistula which has happened, you can close it with the Apollo endoswitch device. I'm also running fast. The methods of closure, we have a hemoclip. We have got a hemoclip by Koch, by Wilson, by Boston Scientific, the clip size of 15 millimeter or 13 millimeter, or we have a Ovesco clips, and we can use the loop and clip methods, and we can use the Apollo endoswitch, which is also possible to close the large defect in the. Now, the few video which Dr. Baiju requested me to show. So this is one of the video where the patient has a large pseudoaneurysm in the gastroduodenal artery. So the management of the fundal varices, we are doing very well with the EUS and the glue and the coil. But this is a large pseudoaneurysm. You see, first the injection was done using the coil and the glue, but the part of the pseudoaneurysm is still patent. Then we again injected the coil after 48 hours, and then the glue was injected. So this is the glue which is coming up, and the complete pseudoaneurysm become obliterated, and you see on Doppler signals the complete, and on Doppler signal you hardly find any. So endoscopic treatment of the pseudoaneurysm, the gastric varices using the coil and glue is possible. Management of where the patient who has a failed ERCP or patient has a gastric outlet obstruction, you can do the EUS guided biliary drainage. either doing the choledochoduodenostomy or doing the antegrade or the retrograde biliary drainage, or you can do the hepaticogastrostomy. This is one of the example. When we did an ERCP patient as a gastric outlet obstruction, we just changed our scope. And from the first part of the duodenum, we punctured the common bile duct. The wire was taken with the cystotome, we dilate the tract, and over which the fully covered SEMS was placed. The important point is you make sure that your fully covered SEMS should not go beyond the port, otherwise it is going to block the one side of the system, one side of the biliary system. So this is the EUS guided biliary drainage is possible where patient has a gastric outlet obstruction, or there's a deformed anatomy, or patient has a previous surgery, or you have a failed cannulation. Endoscopic bariatric surgery, sleeve gastroplasty is there where you do on the greater curvature, right from incisura to the fundus, you reduce the stomach capacity by 30%. But as I said, I don't have a personal experience with this. I borrowed the video from my friend. So endoscopic sleeve gastroplasty is possible. So in my opinion, it is not a competition, it is a collaboration for the best patient care. We all surgeons and the gastroenterologists help each other for management of the patient. Thank you for the patient's hearing.
Thank you, Dr. Rajesh Puri, for the wonderful presentation. It was a brilliant talk. Actually, it has gone beyond my expectations. Thank you once again for giving a vivid picture of how we can tackle with endoscopy itself if the technical support is there. And actually, most of the time what happens is that when endoscopists see the peritoneum through the full thickness perforation, usually they will get frightened and will not do further procedure, and that will be handed over to the surgeon. Here, like a surgeon, you have enough courage to close these things with the whatever amenities available. So congratulations for your presentation. I hand over the mic to Dr.SUNDEEP LAKHTAKIA for proceedings.
Thank you, Dr. Baiju. And thank you, Rajesh, for 3 talks together in one session. I'm sure your mouth must be tired a little bit. You can have some water, have something to eat, recharge yourself, because there are several questions in the chat box, which I'm going through. And the talks were very lucid. And Rajesh, being an expert endoscopist, has several jewels in his crown, and he can manage everything very nicely. So let's start the ball rolling. And the first of the question is from Dr. Jitendra Chauhan. After video-assisted retroperitoneal debridement of necrosis, that is for pancreatic fluid collection, at what time we should go to CT angio to rule out aneurysm? So this is the first question. So this is mainly a surgical question I can understand, because ward is done by surgeons. Generally, it follows a percutaneous drainage path, which is now converted to a larger port of entry. So if you see a blood vessel while doing ward, I think then you can switch over. Do not be aggressive at the time of drainage. We follow the same principle when you do endoscopic necrosectomy. Dr. Baiju, you agree, or Rajesh Puri, you have a different point of opinion?
Yeah, I agree with you.
So my like Sandeep is absolutely right. My feeling is, number one, the CT angio should be done, number one, prior, contrast CT should be done prior to the procedure, number one, to look for the pseudoaneurysm, or while doing the ward or endoscopy, if patient has a bleed, if patient has a hypotension, patient came to the casualty of there is a bleed in the drain, then yes, you should immediately go for the CT angio examination.
Because these patients are not one-time procedures. Sometimes they have repeated procedures which are done over a period of weeks, sometimes even months, days definitely. So you have a percutaneous catheter, then that is cleaned every day or every alternate third day, or you have an endoscopic procedure, symptoms do not improve, and same goes for surgery. So aneurysms may not be there at the beginning of the CT scan, the first index procedure. It can develop sometimes during these periods of observation, which can happen. So if index of suspicion is there, that is a catheter draining fluid or draining blood instead of fluid, or you find blood during endoscopy procedure, or the patient has comes with GI bleed per se, then index, you should do a quick CT angio and then take over from there, depending on what you find. The next question is, what is the timing of necrosectomy? This is from Pranab Kumar Prusti. I think Rajesh would like to take up for that.
Yeah,
Timing
the timing of necrosectomy, I discuss in my talk non-resolving symptoms or the new onset of symptoms.
Correct.
Patient, you have done the drainage, and after 48 to 72 hours, if the patient fever is not going down, or patient is a new onset of fever, these are the indication when you should go for the necrosectomy.
Thank you. That was quick and precise. And how do you manage? Neha Chaudhary is asking, how do you manage a migrated stent inside the cyst?
Yeah, I think this is very simple. You just have to hold the lasso and bring back this. The two important things. You want to readjust the stent or you want to bring it out. You want to bring it out, you just hold the lasso, pull, so the proximal flange will become narrowed. So it is not going to injure. And you bring it out. Second is the important thing comes when you want to readjust the stent. In that scenario, you just pull it out and you make sure that the distal flange should remain in the cavity. That is only take home. But my feeling is once the stent has migrated in, most of the time you do the necrosectomy, it happens while doing the necrosectomy. Then the track is already mature. Then you generally don't require. If your stent has deployed inside while doing the endoscopic procedure in the beginning, then don't try to take out the migrated stent during the time of index procedure. Put another stent, either a plastic or metal. Wait for the track to mature. And after a few days, when you go in, you can take out the migrated stent. In the beginning, when you have done, don't do that.
Absolutely correct. So to make it a little more precise, we sometimes use plastic stents and sometimes use metal stents. If you're not having a good endoscopy tube at the time of placing a plastic stent, we can accidentally push it inside because a lot of fluid gushing out into the gastric lumen or the whichever route of entry, that is esophagus or the duodenum. And sometimes accidentally it can get pushed inside. So even plastics can migrate in. This is more common with metal because they're very short in length and they need a very accurate placement. The biflange stents like Nagi stents have a more degree of difficulty because they're shorter in length and have less lumen opposing capabilities compared to lamps, which has an inbuilt mechanism in axios, step by step, and risk of migration are much lesser. But if it happens to occur, keep your guide wire inside the cyst cavity. That is the lifeline for that patient. So place a plastic stent or a nasocystic tube and come back a few days later when the track is matured, and then dilate the track and take it out or reposition it. One more question from Dr. Siddesh is, any role of overtube in necrosectomy? Rajesh?
I don't think you require an overtube in necrosectomy.
I agree. I've never used overtube for necrosectomy, but it's another addition to the procedure, which is already time taking. So
you can leave your necrotic content into the stomach also. You don't need to take it out. So your question is, you are taking a scope again and again in. Number one, it is a diagnostic scope of 11 to 12 millimeter. That won't create any problem. It is not a large diameter scope. Second is, you can leave your content in the stomach, so there's no need to take out the scope again and again. So I don't think overtube is required.
Okay. There's a question from a senior colleague, Dr. S.S. Sharma from Jaipur, on the need of when do you decide to use hydrogen peroxide for necrosectomy?
Yeah, I think it's a very good question, Dr. Sharma sir.
For irrigation.
Yeah, I have done the hydrogen peroxide in one paper which I published. I've used the diluted hydrogen peroxide, but I think this data is not still scanty about putting an antibiotic, using the hydrogen peroxide. We don't have a scientific data to say that when to use or not. I think it is still an individual preference with a small amount of case reports or the things. Otherwise, we don't have any scientific data. Is that right, Dr. Sundeep?
Yes, we use it sometimes. If we find that the debris is large chunks and adherent to the back wall of the collection, then we place an nasocystic tube and irrigate it. At the second look, if we find that it's still same as what it was 2-3 days back, and it has not changed its character, and it's infected, then we use hydrogen peroxide to loosen it up or make it as a antiseptic agent, anti-infective agent there. But personal use, it's still person to person variations are there. One question also was there, that how much, if you use it, what percentage and how much volume that we use. So I would like to answer that we use 3% hydrogen peroxide. It should be freshly prepared. These come in brown bottles and should never be left open. So because the moment you leave it open, it becomes water and oxygen. So it becomes like a water. Then it's only a psychological impact that you have on yourself, that you have hydrogen peroxide worked. So it should be fresh. Whenever you inject, it should leave some bubbles there, which means that it is now causing changes, that this oxygen-free radicals will work. And do not mix it with saline or anything else. When we usually do it at two times, either at direct endoscopic necrosectomy, at the end of the procedure, we inject and come out, or we leave a nasocystic tube and we feel that it's not working alone with saline, then we use hydrogen peroxide at 8-hourly interval, 3% solution, and not large volume. 10 to 15 ml is usually sufficient for a decent cyst cavity. Do not follow it immediately with saline. Give at least 15 minutes gap after injecting hydrogen peroxide. Let it work, and then finally irrigate with saline. So that's the way we follow it. Whether it works or not, we have never objectively tried to look as a head-to-head trial, but it seems to work in some patients, but it doesn't seem to work in others. So time will tell us if we do any kind of a controlled trial.
People also has a fear, can it produce a damage to the blood vessels or not?
Absolutely right.
Data is not there. It's individually people has done it.
So that's a very good point that you raised, Rajesh. In our experience, what we do is, since it is done bedside, when it is done with a nasocystic tube inside, and a patient complains of pain, then we feel it is some kind of a peritoneal reactions are happening, and then we stop using it. Only saline is used. But if they don't complain of pain of hydrogen peroxide instillation, then you can continue doing it. So that's one way of knowing it. There's a question from Jitendra Chauhan on role of streptokinase in WAN. I don't have any experience in it, and I don't remembering reading it any literature on this. Any experience of that, Rajesh, with you?
No experience, no literature I have read.
Okay. Also, he has a second question on what are the various methods that you use in sudden bleeding during necrosectomy. If you're doing it and you find bleeding, what do you do? You're so aggressive endoscopist now. How would you manage that?
Yeah, so
call Dr. Baju.
So I will tell you the two situations. One, I have shown the video. I was doing the procedure and the patient has a torrential bleed. And within 10 minutes of that, the patient BP fall to 80. And we used initially we thought the bleeding is coming from the cavity. We did every kind of method. We applied the clip, we inflated the balloon, and called the surgeons. We did a CT angio, and trust my word, CT angio was normal. And I was going on the Diwali day, and the same night patient again bled. The repeat CT angio shows there is an injury to the gastroduodenal artery. So it will all depends upon the type of bleeding. While doing the necrosectomy from the cyst cavity, small amount of blood ooze, it hardly make any difference. If you find a little bit of endoscopically visible bleed, so one is called as endoscopically visible bleed and one is called as significant bleed. If patient is hemodynamically compromised or patient is requiring blood transfusion, no doubt about it, you have to go for a CT scan. Otherwise, you just may inject a little bit of epinephrine, or you may apply the hemoclip, or just observe for some time in the cavity and the bleeding stop of its own. So that is the take-home message which I want to give. Rather than a small endoscopically visible bleed, we got panicky and we do multiple procedures, you don't require to do that.
In that gastroduodenal artery bleeding, what did you do?
We did a CT angio and interventional radiology. I showed the videos also. Okay. Dr. Bajal has taken over and they did the clipping.
Okay. Yeah, so mild bleed, wait and watch, they will subside on their own. Major bleed, you need to take help from your IR people. And yes, CT can miss out because some of these vessels go into spasm and may not have even the aneurysms may not be seen. Conventional angio also sometimes can miss them because of the spasm. But one has to be alert and can redo these procedures if required.
And
moving forward, what is the best instrument? Yeah, close. Yes, close observation follow-up is very, very important. Jitendra Chauhan
What
has
if it
asked a
is
question. I'm
what
sorry,
if it
please
is
go ahead.
a venous bleed? Actually, venous bleed.
I think venous
If
bleed
it is a
also
venous
stop on
bleed,
their
yeah.
own. Yeah, these because they can have collateral splenic vein thrombosis, extremely common, and most venous bleeds subside on their own. You can sometimes use the terlipressin or something like that, but it's a give and take which can happen. I think just supportive treatment is more important. Arterial is life-threatening. Venous need not be life-threatening often.
Okay.
Moving forward, there's a question from Jitendra, who's been, I think, listening very carefully to Rajesh, your lecture. What is the best instrument for removing necrosum by minimally invasive surgery from percutaneous catheter? Not endoscopic, he's asking for percutaneous catheter.
So percutaneous catheter means, what I understood is, what is a minimal? Question is?
Question is, what is the best instrument to remove necrosum, the necrotic material by minimally invasive surgery from percutaneous catheter? So it's basically a surgical question. I think Dr.
Actually,
Bajaj
you can use a nephroscope. Actually, nephroscope is having a working channel. You can use nephroscope for necrosectomy by a percutaneous method. So,
Can I intervene in this?
Yep,
yes, please.
So you can do nephroscope, or you can increase the size of the percutaneous drain to 30 French, and then you can take your diagnostic endoscope also.
True.
That has a good working channel, not only working channel, but it has an irrigation also. I have shown one of the paper from the All India Institute of Science, and we have done in our center also. The radiologist colleague, they put the 30 French catheter, we dilate the tract, and we go in with our routine endoscope, and we do the same thing.
Dr. Pramod Garg has very nicely published in his paper of using PEN, percutaneous endoscopic necrosectomy, where they dilate the tract with a large balloon, the achillea type balloon, and then they take their endoscope inside, and then you can see that the necrosum and can be removed by the similar methods. So nephroscope can be used. You can use flexible endoscopes. And some people have also used fully covered metal stents like esophageal stents, through which an endoscope can go inside and remove. So several methods can be tried, whichever is easily available and permissible in the constraints that we have. Because in India, we often have financial constraints by the patient, and not everything may be easily available or possible. Okay, let's move forward again, time being a constraint factor. But there are several questions there, Rajesh, for you. This is my friend from Shafakat from Pakistan, who's asking lamps versus plastic stent in ward of necrosis. When do you do necrosectomy after putting stent time lines? Okay.
So I think this question has been addressed few minutes before. The important thing is, if the patient has a persistent symptoms or patient has a new onset of the fever, in those situations you do the endoscopic necrosectomy. And if the paper has also, the direct endoscopic necrosectomy has been also been done by the people, especially when there's a necrotic debris more than 40%. But I think around 50% of the patient only drainage will be sufficient. So I think you see in totality, but yes, definitely if the patient is symptomatic or new onset of symptoms, you have to go in and do the necrosectomy. And another important thing is, always do a CT scan to look for any adjacent collection. Sometimes a new collection also formed while doing the necrosectomy, and you always feel the prior CT scan also only has one collection. There is a new collections also formed, so you have to take care of that also.
Yeah. So also to add to your answer is that we use plastic stents for pseudocyst or cysts with very small amount of debris, and metal stents are generally preferred for cysts which have large amount of debris, that is one with 20, 30, 40% or more. And then you titrate your need for DEN, that is direct endoscopic necrosectomy, based on symptoms. Another question from the same person from Pakistan is, a patient is very symptomatic and 4 weeks not passed yet. That is, wall is not mature. How would you intervene? That means immature collection. How would you like to intervene?
I think the data is coming even in the immature collection of 3 weeks or 2 weeks also. But my personal preference, and I think still the standard of care, is you do a percutaneous methods. That is the better way of dealing with that.
Yes. Yeah, so percutaneous is the way to go forward in the ill-defined collections. So same person again asking, if pseudocyst drained with plastic stent, do you ever consider removing? If yes, when? Metal we have to remove certainly at 3 to 4 weeks, but plastic stent, what is your take, Rajesh?
Yeah, so it's a very good question. Now I will reply in the two way. Number one, as I said, the pseudocyst happen after interstitial pancreatitis. Pancreatic ductal disruption is not a major important factor in those situations. So you can remove it, number one. When we talk about the VON, where there is a pancreatic ductal disruption and there's a possibility of disconnect syndrome, and from there the concept come, you keep the plastic stent for a longer time. But if you look the literature, the people says when you do the ERCP, only 6% of the cysts reoccur, and among them, a part of them only has a symptomatic cyst. So I think even in the one also you want to remove after 4 to 6 weeks, it is okay. Three things: while removing the metal stent, most of the time the cavity is closed and you don't find a space to put the plastic stent. If you have put the plastic stent, my gut feeling says that there is no data, scientific data to say how long you have to keep. But I think keeping for 4 to 6 weeks is sufficient. If you keep it for a longer, it has no disadvantage. Papers are there where the people has keep for 3 to 4 years also. And the reason is disconnect syndrome. The chances of recurrence of the cyst is there. So you keep the plastic stent for a longer.
So we have our own publication from our group in gut. Jahangir being the first author, that we found that the reoccurrence of the collections is much less. It's disconnected duct is very common. About 60 to 70% patients do have DPDS, as evidenced by MRCP, done about 4 weeks later for patients who have a metal stent. And I believe the same should also be for the plastic stent. But not all DPDS, even if the cyst is still preserved or still remnant, need to have a plastic stent, because reoccurrence of collection is seen only in 10% or less. So that's the risk. Only 10% of the patient, in spite of having disconnected pancreatic, develop a recurrent collection or symptoms. So there is no justification of putting a plastic stent as of now. There were papers earlier from the Belgium group, from Jack Davis group, of leaving this plastic stent permanently for the simple reason of preventing any recollection later on. But that justification doesn't hold true now with the current evidence available. The Japanese also have reported in their literature, Kida's group have said that some of these plastic stents can migrate out over a period of months and years later, and they can cause luminal obstruction, although very rare, but it can happen. So in net, if you have placed a plastic stent and there's DPDS, you can leave it, but discuss with the patient. But if there's no disconnected duct, you can safely remove and tell the patient he should stop his alcohol and smoking, because that's the risk factor of pancreatitis or not DPDS.
Because the total 3 papers, one is from All India Institute of Science, 106 patients, second is from your AIG, and third is from Mumbai. All 3 papers shows the risk of recurrence is 6 to 10%. And among them, 1 to 2% are symptomatic. So you don't require to keep it for a longer time. Yes, if your plastic stent is there, you can keep. Otherwise, you don't require to change from metal to plastic.
Okay, changing gears now from pancreatic fluid collection, which has been very well addressed now. There's a question now on GJ, EOS guided gastroenterostomy. Madhu Shashidharan is asking, did you use Axios GJ on the same patient who had pyloric myotomy? So you showed one patient of gastric gastroparesis where you did myotomy.
Yeah.
Did you actually do a GJ in the same patient, or was it a different patient? I don't think they were same. They were probably different.
Different patient.
And your preference is to do with a freehand technique using a nasocystic tube and rapidly irrigate with saline, a coloring agent with contrast mixed.
I have no other option. I don't have a tube which is invented by Professor Takatoi, so I don't have. So I am only using the freehand technique. The point which I want to mention here, because in India, freehand technique is available. What the people does, they puncture with the 19G needle and put a wire. Please don't do that, because wire pushes the jejunal loop distally, and you feel that wire is going to help. It's not going to help. The direct freehand technique, you distend the jejunal loop, in the mid body, you find the loop of the jejunum,
Is
which is
always
very
better.
close to the stomach, and find a loop which is falling down, puncture that loop. That is the best option. And I have only one option. I did one wire cases, and unfortunately I come across with the complication. So I request, this wire technique is not good technique. We should always use the freehand technique.
So I have some experience now with EUS gastroenterostomy, about 35 or so. But I have always used the double balloon technique from Takao Itoi, which helps in anchoring the jejunal loop very close to the stomach. And you fill this loop with the two balloons inflated so that the jejunum is nicely opposed and anchored well to the stomach. And then you puncture with the axios. So one has to be very perfect in axios delivery system. That's one, because we need to have a lamps, and hot axios is the way to go forward. And try not to put wire, as Rajesh has rightly said. And these should be done only in expert settings, because these are very high risk, high reward procedures. Surgeons can do a much better job than us. They make bigger GJs, wider anastomosis. We only get cases which are not fit for surgery for variety of reasons. If they have very advanced disease, peritoneal disease, or cardiac disease, comorbidities, where surgeons or anesthetist complications are much likely to be more, then we can do these non-invasive, non-surgical, minimally invasive procedures.
What is the diameter of the stent you usually used?
So that stent that is preferred for EUSGJ is 20 millimeter. It's a self-expandable metal stent, and it expands over a period of 4 to 7 days to its full diameter. I personally never try to dilate with a balloon, because that also can add a little risk of migration, although it's very, very less, but let it expand on its own. But patient can take liquids a few hours later, 6 to 12 hours later, they can start with liquids, which is quite reassuring.
And you use a Nagi stent for this one, is it?
No. Nagi is never used for GJ, because Nagi is a biflanged metal stent and has high risk of migration. It does not have as much strong lumen opposing capabilities. So currently there are two stents in the market which can be used for gastroenterostomy EOS guidance. One is Spaxus from Taiwan, and hot axios is from Boston Scientific.
Okay.
Rajesh, you also very nicely covered several other things, which I think will highlight once again. Apart from pancreatic fluid collection and POEM, you covered gastroparesis. But I think it's still very early. Gastroparesis is a physiological problem, and diabetic gastroparesis, I personally feel, will not improve. Just by doing a procedure, whether it's going to improve the gastric outlet symptoms, I am skeptical about it. I'm a conservative endoscopist, and I will think first whether it's going to help, then only I'll try all those stuffs. And Zenker's very nicely, Zenker's several way of doing. You can do Z poem. You can also do direct cutting the bridge which is there with clips. Gastroenterostomy you have covered. There are several ways of doing it. The subepithelial lesions, which are very common. But I would also like to highlight here, now with EUS, we can easily find out what is the likely disease the patient is having. Say it is a GIST, and a small GIST, yes, we are justified to do. But large GIST, I think surgeons can do a better job. Lipomas, I don't think we should touch at all, because it's a benign disease. Why cut a finger, with a sixth finger? If a person has 6 fingers, he can still become a film star. So I personally do not believe in unnecessary interventions just because we have a cyst in the head.
Do you purposely do EFTR, or you are doing EST and then got perforated?
Rajesh?
I will tell you the two things, yeah. So reply to Dr. Baiju and Dr. Sundeep both. So if you look at the literature about the stir procedure, most of the leiomyomas are 2 centimeter or 3 centimeter or 3.5 centimeter. And when the reason was asked why we are doing in asymptomatic patients, number one, the indication made was a little bit of dysphagia, could be because of GERD or so. And second, the patient is fearful, they are after our life, okay, my tumor will grow, and that's why the procedure was done. I absolutely agree with Sundeep. I don't do leiomyoma unless until patient is symptomatic. That's why I've done very few star. That is a question to you. Answer to this question, I agree with you 100%. Now come to the EFTR. Actually, there are many things which require large GIST. Personally, I don't have an experience of closing. I don't have Apollo under switch, so I can close it. I only has a loop and clip method where I can do it. or the duodenal net, where I frequently do a duodenal net. I apply the band, and then if there's a perforation, I use the Ovesco clip and close it. And I think that is minimally invasive doing the duodenal. When we talk about the gastric gist less than 2 centimeter, I still feel we can do a very good job, because it requires 1 or 1.5 hours without intubation in the endoscopic propofol sedation. Patient always surgery, they are fear of surgery. Surgeons open laparoscopic, do a wedge resection. We can do it 2 centimeter and we can close it very nicely. So I think less than 2 centimeter, very easily doable. Yes, if you see the gist, there are the 3 types of gist. The gist which has an intraluminal bulge, the gist which has an intraluminal and intramural bulge, and gist which has a serosal bulge. Serosal bulge you cannot do endoscopically. Intraluminal bulge, yes, you can do it. And the gist which has both, I think in that you have to take a specification where to go surgery or so. But I agree, because we have a less experience. If you see, while doing the EPT, ERCP and EPT and removing the stone with the ERCP, there was the same kind of discussion happening which we are doing for the gist. There is a possibility after 5 years, we are saying the endoscopy is treatment of choice for this. So I think the time is going to tell, but yes, this is one of the method can be done, especially person is high risk for surgery, person is not interested for surgery. So there are various factors which play, yes, but upfront, I advise the laparoscopic surgery. I agree with Dr. Sundeep.
Thank you, Rajesh. I think we are almost nearing the end of the discussion.
And one more question from me. While doing the GERD treatment for this stitching device, so how will you quantify that this patient requires 3 stitches, 2 stitches like that?
So if you see what as a surgeon you do, you take a scope or a bougie.
Yeah.
So same, our scope is there, and when you apply the clip, you see the tightening of the G junction, which very clearly say. But most of the time, patient require 2. Sometimes they may require 3, but 1 is not sufficient completely to encircle completely. 2 is minimum it is required. Your endoscopy is a guide. The device which has gone in the retroflux, you can see, and it is completely a tightening and encircling. That is the indicator that yes, you can do it.
Yeah.
Okay. Thank you.
Thank you, Dr. Rajesh Puri. It was actually a wonderful lecture from you, and you showed almost all videos of endoscopic replacement of a surgeon's procedure. And Dr. Sundeep also moderated it well, and actually you exceeded my expectations really. Thank you, both of you, Dr. Sundeep and Dr. Rajesh Puri, for the excellent work done. And I request you to give the final words.
Thank you. I would like to thank all the delegates who have been posting questions, several questions and comments, and they thank Rajesh and the organizers, Dr. Senadipan, for doing a wonderful job. I think your educational foundation is doing great work, and you have a big fan club from several parts of the world.
Thank you.
This is great news. My friend Dr. Bimal Sheel is there. I have a few friends from Pakistan and Egypt. I'm seeing them here in the screen. It's a great place to be. And Rajesh, being the fantastic endoscopist who is running a great course and leading the Society of GI Endoscopy of India.
Passionate in teaching. Very passionate in teaching. Actually, we can feel the enthusiasm in teaching.
Yes.
Oh, thank you, sir. I enjoyed thoroughly, because I feel this is a one platform where you can speak endlessly, and I'm really impressed by this, because in the conference you give 15 minutes lecture, you are never
Very true.
So I was very happy.
That's a benefit of the virtual meetings. Okay, with that, I think
thank you, Dr. Sundeep and Dr. Rajesh Puri. And next week we have another webinar on chronic calcium pancreatitis that will be given by Dr. H. Ramesh. That will be moderated by Dr. Pradeep Rabela from AIG itself. So till then, bye. Good night to all. Happy Independence Day.
Thank you, sir. Thank you. Bye, Sandeep. Thank you.
Thank you.